Welcome to the deep dive.
Great to be here.
Today, we're embarking on a really crucial exploration, health and wellness. It's such a foundational topic for anyone heading into nursing.
Absolutely fundamental.
We're digging into a key chapter from Fundamentals of Nursing, the 11th edition, by Potter, Perry, Stockott, and Hall, a real cornerstone text.
Definitely one you'll use a lot.
So our mission today, for you listening, is really to cut through all the dense information and just distill the most important concepts.
Yeah, get to the core of it.
We want to unpack how individuals, define health for themselves, how they react when they get sick, and critically, how you as a nurse can genuinely champion well-being in every setting.
Hospital, community, home care, everywhere.
Think of this as your shortcut to understanding these sometimes complex ideas. We'll clarify terms, connect them to the real world, things you'll actually use in your studies, for exams, and definitely in practice.
Exactly. And the goal isn't just memorizing terms, right?
Yeah.
It's about truly grasping that interplay. The physical, the mental, the social, how they all weave together in health.
Right.
We want you to see how your role, your nursing practice, fits into all those dimensions, making the theory actionable.
Okay, so let's dive right in. First question. Seems simple, but maybe it's not. What is health, really? We often just think, well, if I'm not sick, I'm healthy. Absence of disease.
That's the common idea, yeah.
Yeah.
But the World Health Organization, the WHO, they really push back on that.
How so?
Well, their definition is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity.
Okay, complete. That's a high bar.
It is. And what's key is that it immediately flags health as deeply personal. It's unique for everyone. It depends on your values, your personality, lifestyle, culture, even age.
Can you give an example?
Sure. An older adult might define being healthy as, being able to get around, stay connected with family. But a young athlete, their definition might be all about peak physical performance. It's very subjective.
So if it's that personal, how do nurses even begin to approach it consistently? It sounds like it could be different for every single patient.
That's a great question. And that's exactly why we have models of health and illness. They're like tools, frameworks to help us understand patient attitudes and behaviors about their health.
Okay.
They help us see, for instance, that positive behaviors, immunizations, good sleep, nutrition, they maintain health, while negative ones like smoking or a really poor diet actively harm it.
Makes sense. So what's one of these models?
A really important one is the health belief model. It helps explain why people do or sometimes don't take action regarding their health.
Okay. How does it work?
It basically has three main parts. First, perceived susceptibility. Does the person actually believe they are at risk of getting a particular illness?
If your whole family has heart disease, you might feel pretty susceptible yourself.
Exactly. That's perceived susceptibility.
Yeah.
Second is perceived seriousness. How bad do they think the illness would be if they got it or if they already have it?
So someone might have high blood pressure but not see it as a big deal.
Precisely. And if they don't see it as serious, they're, less likely to manage it effectively.
Yeah.
Their perception drives their action or inaction.
Got it. Susceptibility and seriousness. What's the third part?
The third is the likelihood of taking action. This comes down to weighing the perceived benefits of doing something like changing their diet against the perceived barriers like cost, time, or difficulty.
So it's a cost-benefit analysis in their head.
Kind of, yeah. If the benefits seem to outweigh the barriers, they're more likely to act. Understanding this whole internal calculation is crucial for nurses. You can't just lecture. You have to tap into their beliefs.
Okay, that model seems focused on avoiding illness. Are there others?
Yes. Another key one is the health promotion model, or HPM. This one frames health differently as a positive, dynamic state. It's less about avoiding sickness and more about actively increasing well-being.
So more proactive.
Exactly. It looks at the individual's characteristics, their past experiences, and what specifically motivates them to change their behavior-specific cognitions. And then, ultimately, their commitment to making that change happen. We, as nurses, try to influence those factors.
Interesting. What about Maslow? I feel like everyone sees that pyramid.
Yes. Maslow's hierarchy of needs, you're right, is usually shown as that pyramid. Physiological needs at the base.
Yeah.
Then safety, love and belonging, self-esteem, and finally self-actualization at the top.
Food, water, shelter first, right?
Generally, yes. But here's the really important nuance for nursing. While it is a hierarchy, you have to prioritize the individual patient's need in that specific moment. It's not always strictly bottom-up in practice. Well, obviously a severe breathing problem that's physiological that always comes first. But Think about a patient who's just had a mastectomy. Yes, pain control, a physiological need, is vital,
Mm-hmm.
but maybe their greatest immediate need relates more to love and belonging or self-esteem because of the change in their body image.
Ah, okay. So you assess what's most pressing for them.
Exactly. You assess, you don't just assume based on the pyramid structure. It's about seeing the whole person.
And that leads nicely into the last model you mentioned.
It does. The holistic health model, this one really emphasizes that connection between body, mind, and spirit. It's very patient-centered. It sees the patient as the expert on their own health.
So it might involve things beyond typical medicine.
Absolutely. Things like meditation, music therapy, maybe reminiscence for older adults, guided imagery, even therapeutic touch. It's about integrating these complementary therapies.
Yeah.
And this connects directly to what the textbook highlights in its evidence-based practice. Box the power of culturally sensitive approaches. Using community health workers, like promotores in Latino communities. Leveraging faith-based support. These holistic, culturally grounded strategies can be incredibly effective, especially for vulnerable groups.
It really paints a picture of health being about someone's entire context, their whole world.
It absolutely is.
So if health is that personal and holistic, what are all those things, those internal and external forces that actually shape someone's health beliefs and practices day to day?
Great question. Let's break down the internal variables first. Things inside the person.
Okay.
Your developmental stage is a big one.
Yeah.
How a child understands illness, their fears, is totally different from how an adult might cope.
Makes
Right.
sense.
Then there's your intellectual background. Education level, sure, but also traditions, past experiences with illness. They all shape how you understand health information.
Right.
Also, your perception of functioning. This is about how you feel versus objective measures. Subjective data is like fatigue or pain, what the patient tells you. Objective data is what we measure: blood pressure, lung sounds. We need both to get the full picture of their reality.
And emotions must play a part too.
A huge part. Emotional factors like stress, depression, fear. They directly impact how people react to illness and whether they stick to health advice. How someone typically handles stress is often a good predictor of how they'll cope with a diagnosis.
That's insightful.
And finally, don't underestimate spiritual factors. Spirituality, finding meaning, values, hope, or specific religious practices can strongly influence health decisions. Think about dietary rules or beliefs about blood transfusions, for example. Recognizing these internal factors is key for truly individualizing care.
Okay, that covers the inside. What about the world around the person, the external variables?
Right. First up is family role and practices. How your family approached health, whether they emphasized prevention or maybe held certain misconceptions, say about diet, that shapes you from childhood. Healthy habits modeled early are more likely to stick.
Sure, you learn from your family.
Definitely. And then we get to something hugely important, something you really need to understand for your practice: social determinants of health, or SDOH.
SDOH. I've been hearing that a lot.
You will. It's critical for understanding why some groups have poorer health outcomes than others. SDOH are basically the conditions in the environments where people are born, grow, live, work, and age. They're non-medical factors, but they have a massive impact on health.
What kind of conditions are we talking about?
The textbook lists 5 main categories: economic stability, think poverty, employment, food security, education access and quality, healthcare access and quality, having insurance, access to providers, social and community context, social cohesion, civic participation, discrimination, and neighborhood and built environment, access to healthy foods, quality of housing, crime rates, environmental conditions.
Wow, that's a lot. Can you give an example of how that plays out for a patient?
Sure. Imagine a patient with diabetes. If they're living in poverty, economic stability, maybe they can afford healthy food options available in their area, neighborhood-built environment, or perhaps they lack reliable transportation to get to their doctor's appointments,
Right.
healthcare access.
Right.
These aren't medical issues per se, but they directly impact that patient's ability to manage their diabetes. They might have to choose between buying medication or paying rent. Understanding SDOH helps you see those bigger barriers and advocate more effectively.
That makes it very clear. What else is external?
The last big one is culture. This really falls under that social and community context umbrella. Culture influences everything: beliefs, values, customs, how people communicate, even how they express pain or interact with healthcare providers.
So eye contact, for example, means different things in different cultures.
Exactly. It's absolutely vital for nurses to provide culturally competent care. That means being aware of different cultural norms, yes, but also avoiding stereotypes. People within any cultural group vary hugely. And it also means examining your own cultural assumptions. It's a continuous learning process.
It sounds like there are just so many factors influencing a person's health.
There really are. It's complex.
So how do we in healthcare respond to all this? Let's talk about health promotion, wellness, and illness prevention.
Right. These three are related but distinct. Health promotion is about activities that help people maintain or enhance their current level of health. Think encouraging exercise or good nutrition.
Okay.
Health education is part of that, providing information so people can understand health and make informed decisions, like teaching stress management techniques.
And illness prevention.
Illness prevention focuses on protecting people from actual or potential health threats. Immunization programs are a classic example. It's about reducing risk.
Are there different ways health promotion happens?
Yeah, we talk about passive versus active strategies. Passive means individuals benefit without doing anything themselves, like fluoride added to the public water supply or vitamin D fortified milk.
Ah, so it just happens to you.
Exactly. Whereas active strategies require the individual to personally get involved, like joining a weight loss program or starting an exercise routine.
Gotcha.
The big picture goal for all of these is, of course, better health outcomes, improved well-being, and also trying to reduce healthcare costs by empowering people to manage their own health and prevent illness where possible.
Okay, that makes sense. So we need a way to categorize these efforts, right? Especially for exams and practice, understanding when we intervene is key. This brings us to the 3 levels of prevention, doesn't it?
It absolutely does. These are fundamental. You will see these on the NCLEX and use them constantly. First is primary prevention.
Primary, okay.
This is true prevention. It aimed to reduce the incidence of disease, basically, stopping it before it even starts.
Like putting up a shield.
Kind of. Examples are health education about risks, immunizations, promoting physical fitness, using hearing protection in noisy workplaces, preventing the initial problem.
Okay, primary is before anything happens. What's next?
Secondary prevention. This focuses on preventing the spread or worsening of disease after it has already started.
So the disease exists, but you're trying to catch it early or stop it from getting worse.
Exactly. Early diagnosis and prompt treatment are key here. Think screenings, mammograms, colonoscopies, blood pressure checks, or treating diabetes in its early stages to prevent complications down the line, acting quickly once something is detected.
Right. Primary, secondary. So the last is tertiary.
Correct. Tertiary prevention. This comes into play when a disease or disability is permanent and irreversible. The goal isn't cure, but minimizing the long-term effects, preventing further complications, and helping the person adapt and function as well as possible.
So this is more about managing long-term impact.
Precisely. Rehabilitation is the core of tertiary prevention. A classic example is helping someone who's had a spinal cord injury learn to use a wheelchair effectively, adapt their home, and manage daily activities to maintain the highest possible quality of life and independence. Or helping someone with a chronic illness find suitable work.
Those levels, primary, secondary, tertiary, seem like a really practical framework for nurses.
They are incredibly useful for planning care.
Okay, let's shift gears slightly and talk about risk factors. The textbook defines these as attributes that increase vulnerability to illness or accidents, like an impaired gait being a risk factor for falls.
Exactly. And it's important to remember, risk factors don't cause the disease directly, but they definitely increase the chances of it happening.
And these aren't all the same, are they? Some you can change, some you can't.
Right. We divide them into non-modifiable risk factors, things you're stuck with, basically. Like age is a big one. Infants are more susceptible to certain infections. Older adults have higher risks for heart disease and cancer. Gender plays a role. Men tend to have higher cardiovascular disease risk before menopause, while women have higher asthma risk after puberty. And then there's genetics and family history, things like predispositions to certain cancers, diabetes, heart disease.
But you mentioned family history can be tricky.
It can be, yeah. Sometimes it's hard to separate a true genetic link from shared environmental factors or lifestyle habits within a family.
Okay, so those are the non-modifiable ones. What about the ones we can influence?
Those are the modifiable risk factors, and this is where a lot of nursing intervention and health promotion focuses.
Makes sense. What falls into this category?
The big ones are lifestyle behaviors. Smoking, excessive alcohol use, an unhealthy diet leading to obesity, lack of physical activity, not getting enough rest or sleep. These significantly raise the risk for a whole host of chronic diseases. The book also notes specific risks for young people, ages 10-24, like unintentional injuries and risky sexual behaviors. And don't forget chronic stress and environmental factors, like exposure to harmful chemicals or living near toxic waste sites. Sometimes these can be modified, though it might be difficult.
It really sounds like changing those modifiable behaviors could make a huge difference. But that seems really hard to do in practice. People get stuck in their ways, don't they?
It is hard, absolutely. Change is difficult. That's why simply identifying risk factors isn't enough.
So what do nurses do? How do we help people actually change?
Well, first, we use our assessment skills, maybe specific health risk appraisal tools. But honestly, the absolute key is patient motivation. They have to want to change. They won't do it just because we tell them to. They need to see the need for themselves and be willing to put in the effort.
Okay, so motivation is paramount. Is there a model for understanding that process?
Yes, and it's another really useful one. The Transtheoretical Model of Change. It outlines stages people typically go through when attempting to change a health behavior.
Yeah.
And importantly, it's not always linear. People often cycle through stages, and relapse is common. It's part of the process.
Okay, walk me through the stages.
Sure. First is precontemplation. The person has no intention of changing behavior in the foreseeable future, maybe the next 6 months. They might say something like, me? No, I don't have a problem, or there's nothing I need to change. They might not even be aware their behavior is risky.
Okay, so they're not even thinking about it.
Right. Then comes contemplation. Now, they're aware a problem exists and are seriously thinking about overcoming it, but they haven't committed to action yet. They might say, yeah, I know I should probably quit smoking. I'm thinking about it. There's a lot of ambivalence here.
Weighing the pros and cons.
Exactly. The next stage is preparation. Here, the person intends to take action in the near future, maybe the next month. They might have already started making small changes.
Like cutting down before quitting smoking completely?
Precisely. Or they might say, I bought running shoes. I'm going to start next week. They're getting ready.
Okay, pre-contemplation, contemplation, preparation. What's next?
Action. This is where the individual actively modifies their behavior. They're exercising regularly, they stop smoking, they're sticking to their diet. This stage requires real commitment of time and energy.
This sounds like the doing it phase.
It is. But it's not the end. The final stage is maintenance. This is about sustaining the change over time, usually defined as 6 months or more. The focus here is preventing relapse. They might say, I make sure to avoid situations where I'll be tempted to smoke.
And you said relapse can happen at any point.
Yes, and it's crucial to see relapse not as failure, but as a learning opportunity. Understanding these stages helps us tailor our interventions. You wouldn't push someone in pre-contemplation to set action goals, right? You'd focus on raising awareness first.
That makes so much sense. Match the intervention to their readiness.
Exactly. And the textbook has a great patient teaching box on lifestyle changes. It emphasizes active listening, building rapport, helping patients identify their own barriers and strengths, setting small, achievable goals like that 150, 300 minutes of moderate exercise per week, maybe logging changes, using culturally appropriate materials involving family.
And checking understanding.
Critically important. Using the teach-back method, asking the patient to explain the plan back to you in their own words is the best way to ensure they've actually understood it.
Wow, okay. That model really highlights the journey of change. Now let's talk about the impact of illness itself. Because getting sick isn't just about the physical body, is it?
Not at all. And it's vital to distinguish between illness and disease.
Okay, what's the difference?
A disease is typically a medical term. It refers to a pathological change, a malfunction of the body or mind, like cancer or multiple sclerosis. They're usually objective signs and symptoms.
Right, a diagnosis.
Yes. But illness is different. It's a subjective state. It's how a person feels about their health, whether or not a disease is present. It's a state where their physical, emotional, intellectual, social, developmental, or spiritual functioning is diminished or impaired compared to how they usually function.
So you can have a disease but not feel ill.
You absolutely can. Think of someone with early-stage hypertension who feels perfectly fine. Conversely, someone can feel ill, tired, stressed, run down without having an identifiable disease. As nurses, we have to address the illness the person's experience, not just the disease label.
That's a really key distinction.
It is. We also differentiate between acute and chronic diseases. Acute illnesses usually have a rapid onset, intense symptoms, and are relatively short-lived, often reversible, like the flu or appendicitis.
Okay.
Chronic illnesses, on the other hand, typically last longer than 6 months, are often irreversible, and can affect functioning in multiple ways. Think diabetes, heart failure, arthritis. Their symptoms might fluctuate, sometimes better, sometimes worse.
And chronic diseases are a huge issue, right?
A massive issue, especially in the U.S. And importantly, many are linked to those modifiable risk factors we talked about: diet, smoking, inactivity.
So, how do people react when they do get ill? Is there a pattern?
Well, we talk about illness behavior. This is how people monitor their bodies, define and interpret their symptoms, take action, and use the healthcare system. It's highly individual,
Influenced by their background.
definitely. Personal history, social norms, culture, they all shape illness behavior. Sometimes adopting the sick role can even be a coping mechanism, maybe offering a temporary release from usual responsibilities.
What influences how someone behaves when ill?
Both internal and external variables.
Hmm.
Internal ones include how they perceive their symptoms. Are they disruptive?
Frightening.
Their coping skills and their locus of control. Do they feel they have control over their health? Or is it up to fate or powerful others?
And external.
External variables include how visible the symptoms are. People often react more quickly to visible symptoms. Also, there are social groups' norms about illness, cultural background, economic factors, can they afford to be sick, healthcare accessibility, and social support.
It seems like illness doesn't just impact the person physically.
Oh, absolutely not. The impact of illness on the patient and family is profound and multifaceted.
Tell me more about that.
Well, first, there are behavioral and emotional changes. These vary hugely. Short-term illness, like a cold, might just cause irritability. But a serious, life-threatening, or chronic diagnosis like ALS can trigger shock, anxiety, denial, anger, withdrawal stages similar to grieving.
Okay.
Illness also has a major impact on body image. Body image is subjective, how you see your physical self. Any change, whether it's from surgery like an amputation or mastectomy, or even less visible changes like chronic fatigue, limiting activity, can profoundly affect body image and trigger that grief process again. Shock, withdrawal, acknowledgement, acceptance.
And that must affect how people see themselves overall.
Exactly. It impacts their self-concept, their overall mental self-image, which includes body image but also performance of roles. If illness changes how they see themselves or what they can do, it can create real tension, especially in relationships.
Which leads to family impacts.
Directly, there's often a significant impact on family roles. Role reversal is incredibly common. Think of an adult child suddenly needing to care for an ill parent, or one spouse taking on all household duties when the other is sick.
That must cause a lot of stress.
Immense stress and potential conflict, especially if the changes are long-term. Families often need support, sometimes even counseling, to navigate these shifts.
So it changes how the family works together.
Definitely. That's the impact on family dynamics. How the family functions as a unit, makes decisions, copes. All of that changes when a member becomes ill, especially seriously ill. It underscores why nurses must include the family in the plan of care. We support the whole unit, not just the patient in the bed.
That's such a crucial reminder. Care extends beyond the individual. And thinking about the caregivers, that brings us to something really important but often overlooked: the nurse's own well-being.
Yes, this is absolutely critical.
So what does all this mean for you, the nursing student listening, and for practicing nurses?
It means we need to talk about compassion fatigue. This is a serious occupational hazard for nurses and other caregivers.
It's more than just being tired.
Much more. It's described as a combination of secondary traumatic stress, STS, and burnout, BO.
Okay, break those down.
STS comes from the trauma of witnessing patients suffering frequently. You absorb some of that trauma yourself. Burnout, on the other hand, stems more from the work environment, chronic lack of resources, feeling overwhelmed, maybe poor staffing, lack of support, excessive demands.
And together, that's compassion fatigue. What does it look like?
The symptoms can be wide-ranging and really impact your life and work. Things like a decline in your own physical health, changes in sleep or eating patterns, feeling emotionally exhausted, becoming irritable or anxious, having trouble concentrating.
That sounds serious.
It is. It can also lead to feeling hopeless, having diminished empathy for patients, which is core to nursing, making poor judgments, being absent from work more often, and generally performing poorly. It really undermines your ability to care effectively and compassionately.
So what can nurses do? How do you protect yourself?
There are both personal strategies and professional strategies, meaning institutional support. Personally, it boils down to prioritizing self-care, which is easier said than done in nursing, but vital.
Like what kind of things?
Eating well, getting enough sleep, which could be tough with shift work, regular exercise and relaxation, finding ways to balance work and family life, developing strong coping skills, allowing yourself to grieve the loss of patients, tending to your spiritual health.
Finding support.
Yes, finding a mentor, someone who gets the unique stresses of the job, can be incredibly helpful.
And what should healthcare organizations do? The professional strategies.
Institutions have a responsibility here too. They can offer educational programs about compassion, fatigue, and resiliency, provide opportunities for debriefing after difficult events, establish support groups, and ensure access to mental health professionals for staff. Creating a supportive work environment is key.
Building that resilience seems crucial for a long career in nursing.
It absolutely is. You have to care for yourself to be able to effectively care for others long term.
Wow. We've covered so much ground today. From the very definition of health, through the models we use to understand patient beliefs, like the health belief model and the stages of change.
And all those internal and external factors, especially the social determinants of health.
Right, and the different levels of prevention, the impact of illness on patients and their families.
And wrapping up with that crucial piece on nurse self-care and compassion fatigue.
It really highlights that understanding these concepts isn't just about passing exams. It's truly about delivering that holistic, patient-centered care we keep talking about. It's about navigating the real, messy, complex world of healthcare.
Absolutely. Your ability to really get these dynamics, how individual beliefs interact with huge societal factors like SDOH, how illness unfolds and impacts families. That ability will fundamentally shape how effective you are as a nurse.
Yeah.
It's about being observant, being empathetic, and being flexible, always ready to adapt your care to what that specific patient and their family needs in that moment. This deep dive into health and wellness concepts is just a critical foundation for becoming that compassionate, effective nurse.
Well, we really hope this deep dive has sparked some aha moments for you and maybe made the path forward in your studies feel a bit clearer. Keep asking those questions, keep learning.
And please keep caring for yourselves as you prepare to pour so much into caring for others.
Here's a final thought to leave you with. How might your own personal definition of health change and evolve as you move through your nursing career, as you encounter all the diverse patients and their unique stories and journeys?
That's a great question to reflect on.
Thank you so much for joining us on the deep dive.
Yeah, thanks for listening.
Until next time, keep diving deep.